management for Halton CCG. I've worked in Halton for quite some time now, and most of you may have seen me before. My role has slightly expanded in that I'm covering Warrington now as well. But yeah, I have worked with Halton GP practices and with Halton patients for quite some time, and hopefully you'll find this quite an interesting, just an update on what we've been doing in the last 12 months. So like I say, for those of you who know me, we've got a lot of things that we are involved in, but the last year's been challenging, shall we say. So thought you might be interested to sort of hear some of maybe the things you've heard about before and where we've got up to with it. Nathan, do you want to introduce yourself?
I can find out how to unpause. Hello, everyone. My name is Nathan O'Brien. I'm one of the medicines management pharmacists that works with Lucy. I support across both Witness and Runcorn, and provide a number of different functions, some of what we'll talk about today, if that's okay. Do you want me to
yeah, please.
Slides on? See, thank you.
Yes, thank you. Thank you. Okay, so just to start off, I think that over the last 12 months, yeah, so much has gone on. Things have changed. It was unprecedented. But basically, patients still needed to get their medicines, and that was something that didn't change. It's still the most common thing that your doctor or clinician is likely to do for you, and it is the second biggest cost to the NHS after staff. And throughout all of this was one of the prime things that we needed to make sure that we mobilized to make sure that whilst the prescribing, it needed to happen, patients needed to have their medication. Given that the changing ways of working, it still needed to be safe, it still needed to be the most evidence-based, it still needed to be cost effective in many ways. I think at the end of the day, everyone hates to talk about the cost associated with medicines, but like I said, it is the second biggest thing we spend money on in the NHS. So for those of you who don't know, Halton have a medicines management team, which is a group of pharmacists and pharmacy technicians. I would say they've all worked in the area for some years now, so know the practice as well. Many of them live in the area, so are also very familiar with the Halton area. But basically, over the last 12 months, what we did was we changed our work program very, very quickly. We looked at what needed to be done. How did we need to support the front line, make sure that patients did have access to these medicines, the safety, that there was the issues that were coming up with regards to access were resolved. And that basically we supported the whole system from patients through to clinicians, and then linking in with our partners in the trusts and community pharmacy and other areas, us sharing a network of information across colleagues, just to make sure we did what we needed to do to support with regards to medicines. We did have to work remotely a lot, which was a challenge, but actually once we got into the swing of it, there was no, it was really quite amazing how much work we got through via that route. A lot of the clinicians in the practices were also working remotely, so it was just a different way of working. So all our clinical staff had access to the clinical information they needed, and that was all done safely and legally through the GP practices, so that we weren't doing anything we shouldn't have done. And interestingly, in Halton, we have over the years, I've always made sure that the team have developed and they're skilled up, and that they've got the clinical skills to support our patients and our clinicians. And we have pharmacists who work on respiratory, which was really good, because obviously she mobilized into making sure she supported that element of it, cardiovascular, all those different pharmacists that we have took on different areas, even if it wasn't necessarily their specialist area, and made sure that we had support across the patch for that. And our technicians very much supported our practice staff in making sure processes worked smoothly, given the different ways of working. And then just finally for me, but you'll hear more about it, but I think it's something you don't hear about. The COVID vaccination programme has been a huge part of our work that has taken up a masses of our time, and still does to some extent, since probably about November onwards. And Nathan will talk to you a bit more about that. But the reason we've got this in is not just obviously because it's a huge thing at the moment, but I don't think it's probably been made quite as public as it has with other teams supporting the vaccination program, quite what we've done to support that and what pharmacist involvement there's been in that. So I'll hand over to Nathan. He'll go through a few of the key things that's happened that we've done over the last 12 months. So Nathan, over to you.
Thank you, Lucy. So just slides to move on. So one of the things that I'd like to discuss this morning was the minor ailments and self-care topic that we had worked on just before COVID. We had got to the point where we were hoping to launch our self-care in Halton program, and it was delayed because of COVID, and to better adapt and equip our local practices and other teams with COVID response. So it would be something that we would like to just highlight again as something that we would plan to pick up in the not too distant future. Some of you may be already familiar with this information, but it's still quite important and relevant. And as Lucy says, expenditure on medicines is probably one of the largest next to staff costs in the NHS. And so the example there being on screen, that there's approximately £500 million per year spent on prescriptions for medicines that could otherwise be purchased over the counter or at other places such as maybe petrol stations or supermarkets. The NHS England asked us to consider as CCGs 4 groups of different medicines. So for example, as it says there, medicines that are used to treat conditions that are considered to be self-limiting. So that basically means that things that will get better on their own without much intervention from a doctor or other healthcare professional. Number 2, conditions that lend themselves to self-care. And so that potentially could be something like allergies, where you could obtain antihistamines from maybe a supermarket or pharmacy, or the occasional headache or strain or other item that happens day to day that most people can sort out themselves without much difficulty. The third group there is items that can be used or purchased over the counter at low cost, and particularly the principal point being at a lower cost than can be accessed by the NHS. So there's a number of items that when they are procured through the NHS, for example, on prescription from your GP or from other services, potentially would cost a substantial amount more than what they would be if they were simply purchased over the counter. And then finally, the fourth group is medicines that potentially there's very little evidence of clinical effectiveness in their use. And so that's something that is quite important. There's a number of things that some people still like to use, but substantial research and evidence has gone into their benefit, and they just don't have the effect sufficient to warrant them being prescribed on the NHS. And so an example of this is what's on screen. I'm sorry, there's a lot of text, but it's just to give the example there that there's often many minor conditions that can be treated. The main example given is 12 anti-sickness tablets have been evaluated by the NHS as costing roughly about £2.18 from a pharmacy, whereas the cost to the NHS would be over £3, including dispensing fees. And then when you consider all the other administration costs and the cost of GP consultation, that quickly escalates up to a figure of around about £35. And so for the ability of someone to walk into a pharmacy and spend £2.18, that money could quite quickly escalate in an NHS situation to roughly about £35. And that figure has been taken across the whole scope of the NHS. So it does account for many different types of prescription items. The principles of self-care are very important. So as it says there, self-care provides people with the ability to take greater control of their health and well-being. This is something that's very important. We have a great drive in the NHS to encourage people to be more involved and responsible for their treatment and medication. This often leads to better patient outcomes. People are happier with their treatment, and when they have that control, they're much more involved in their treatment, and as a result of being involved with their treatment, the benefit of the treatment often improves substantially. And so that's something that's very much an important factor of self-care. Another aspect is by reducing spend on treating conditions that are self-limiting and lend themselves to self-care. And so those 4 principles that we discussed previously, items of limited clinical effectiveness, the resources that can be saved when we consider reducing the money that would be spent on those items, can then be funneled or allocated to higher priority areas, and therefore generate a better and greater impact on patient care. And so £550 million across the NHS is quite a substantial figure. And so if that money could be better allocated to more important or useful resources, it's something that would be a definite benefit to everyone across the health service. And self-care also supports improvement with services and delivery and transformation, and ensuring long-term stability of the NHS. And so it's always a very common news item. The NHS often struggles for resources and for finances. It's probably one of the largest organizations in the world, which is adapted specifically to healthcare. And so it's quite important that we use the funds that we get from taxpayers to provide the best possible service that we can. And we want to ensure the NHS is fit for purpose for years and years to come. And so that's something that we need to really reflect upon. And when people promote and implement self-care principles in their day-to-day lives, that is definitely seen to produce a great support to the NHS services. Some of you and many of you may have seen these resources before. So before COVID, we developed quite a number of different resources to support with self-care and promoting it across our local area. We have a number of posters. We have a leaflet, as you can see there in the center. I don't know if you can see my arrow. We also developed a self-care policy, which is very much adapted to the needs of our local population. We took the approach locally that we would give our GPs a very firm scope to operate in the best interest of each individual patient. And so by doing so, we hope to mitigate any issues that may arise from challenges with deprivation or poverty, or making sure that patients are supported in every aspect of their treatment. Self-care principles also promoting use of community pharmacies, and we're also in the process and have developed website links, and the link to the Halton CCG website as well now contains a number of these resources, and we'll continue to update and improve that as we go forward with the work of self-care. And so these are some of the resources that we have. Just moving on. one important aspect of self-care is that people have access to medicines effectively. One of the services that we commission locally is Care at the Chemist. Care at the Chemist provides advice and treatment for a wide range of minor conditions, a list of which we've put on the slide here. And so each of these minor conditions can be supported without the need to visit a local GP, but instead we can access one of our local pharmacies. Our pharmacists are all highly trained healthcare professionals with a substantial experience and knowledge of medicines and how they're used, and provide safety and other important information to the public. We have over 30 local pharmacies in Halton, so there's quite good access, which is much more prevalent than our 14 GP practices. And so some of these conditions you don't need to see your GP for. You can just go into your pharmacy and get that consultation with the pharmacist, and then, if appropriate, receive treatment and care that would be helpful to you. A wonderful benefit of Care of the Chemist is that we can provide medicines on this service at substantially lower cost than prescription. And so this is an NHS commissioned service, and so the medicines that are provided and the advice and guidance are at NHS cost. But when we calculate it all up, compared to the cost of generating a prescription and all the things that are attached to that, Care of the Chemist does substantially reduce that impact on NHS finance. And then also in point 5 there, that you'll note that if you're exempt from prescription charges, you'll also be exempt from charges on this service, which is also important. And so individuals that are exempt would be exempt also here. Next section here relates to the work that we've done as a team in relation to managing medicines and medicine safety. And so many of you will recall right at the very beginning of COVID, we had issues in relation to paracetamol and ibuprofen supplies when they all went out of stock and many places couldn't obtain them. We worked very hard at providing information, advice and guidance to our GPs, our local pharmacies, and other partners in order to support patients in the management of that situation. It was very challenging because of the information coming out. Initially, I believe it was somebody from the French Health Authority that had indicated that ibuprofen wasn't safe in the treatment of COVID. That later turned out not to be true, but in the interim, it caused quite a vast problem with the supply of paracetamol and other medication items. And some of the work that we did in that relation to that was quite important, advising patients, sending out information to support with our prescribers and with our pharmacies, and just to make sure that everybody had the right information as timely and as quickly as an opportunity as possible. Some of the other work that we did, it was in relation to monitoring repeat prescribing, prescription ordering, and encouraging appropriate electronic repeat dispensing of prescriptions. This was principally to ensure that everybody had the medication that they need at the time that they needed it. As Lucy said previously, prescribing didn't stop because of COVID. And so there was quite a lot of work to be done to ensure that things such as stockpiling didn't occur, that patients received the medication they needed, and that GPs were supported with all the normal functions of medication advice and guidance that we normally supply. We also supported people to take only the medications that they needed safely. We provided advice and guidance about a number of things. You'll be aware that there was quite a large hype about things like hydroxychloroquine and other medications during COVID. And so we were supported substantially with information and guidance and advice about those sorts of issues and topics. There was information about vitamins and minerals and all sorts of different remedies and other approaches to treating COVID, much of which is, if not all, has been substantially debunked as we've gone forward. And so the important part of that was that we ensured to the best extent that we could patient safety by providing the right information, the right advice to patients and also to our prescribers in the practices. We also supported with the prevention of stockpiling of medicines. And so one of the ways that we did this was to ensure that prescriptions continue to be ordered monthly or thereabouts from each GP practice. And we also supported substantially, as Lucy probably will discuss later, about our care homes and other organisations, just making sure that that supplies were maintained, and we protected the NHS supplies that we had across the board. And the work that was related to this was quite substantial. We also did a good bit of work around end-of-life care provision. A lot of the work that happened during COVID moved to electronic functionality. And so we provided administration sheets for end-of-life care that were electronic. This prevented footfall and unnecessary access to GP practices. It made access to information about end-of-life care more readily available to people like our district nurses and our specialist palliative care teams. We also monitored and supported with the supply of end-of-life medicines, as we did with many other medicines as well. And we also developed a special COVID GP urgent pharmacy delivery service. And so one of the things that became apparent as COVID went on, that there are certain individuals that required access to medications in a very, very timely manner. And as such, it was important that we were able to communicate effectively between our GP practices and our pharmacies, and then ensure that the medications that were prescribed were delivered. And sometimes that would be necessary within a 24-hour period. And so Lucy and the rest of the team did quite a substantial amount of work in relation to getting that service up and functioning, so that medication could be delivered as soon as possible to the patients that needed it when they needed it. And thankfully, we had access to those type of resources as COVID went through. And then on top of that, we also maintained all our other normal medicines management services and NHS medicine safety work. Still providing advice and guidance about how we implement our local formulary, how we support with patients with everything from swallowing difficulties to drug interactions. We have done a lot of work in relation to developing COPD and cardiovascular medicines work to support with a variety of different projects across the board, and all again to improve and maintain the patient safety and the quality of care that we provide across the area. And then finally, moving on to a little word about the how we've supported with the local vaccination program. And we have, as Lucy said, we've got our team of pharmacists and pharmacy technicians that have provided a great deal of support. We've supported our doctors and other healthcare professionals and trained volunteers to provide the vaccination. This has been something that's been quite important. We've done work with the Cheshire Fire Service recently, providing the vaccination to people. We've set up vaccination sites both in the stadium on the Witness side and in the Brindley on the Runcorn side, and also supported with vaccinations in care homes and from a limited number of other GP practices as well. the directive came out from NHS England and from the government that pharmaceutical oversight was essential to maintaining a high standard and quality around the vaccine, and that was one of the things that was highlighted as being very important, and the majority of that responsibility fell to Lucy and the medicines management team, both across Halton and Warrington, in relation to ensuring those high standards and the quality of the vaccination program. A lot of the work that we've done has been principally around about safety and legality of the vaccination. There are national protocols that must be followed, and standard operating procedures, as we have their SOPs. And this all provides important governance to ensure that that the vaccine is provided to patients in a legal and safe way, and preventing any, where possible, preventing any harm or any difficulty with the vaccine whatsoever. Every one of the reassurances that we have by following these procedures, that every vial of vaccine has been inspected and protected right the way through its handling process. And so every pharmacist, doctor, nurse, or trained volunteer will have received training and advice and guidance as how to handle the vaccine, how to store it, and ensure that it's maintained at the highest possible standard in order to ensure that everyone is vaccinated properly, and that the vaccine has its most optimal opportunity to be effective. And this all involves quite careful planning and substantial amount of documentation. The paperwork that has been involved in the vaccination rollout program has been very substantial, and our team have supported substantially with ensuring that each protocol or standard operating procedure or piece of governance has been assessed and dealt with in the best possible way that adapts to local circumstances. Some of the work that's been done also involved the storage for temperature sensitive products. So as you probably have heard in the media, the vaccine, particularly the Pfizer vaccine, has to be stored very, very carefully in fridges. It's delivered when it's produced and transported. It's somewhere in the region of -70 degrees Celsius, and then has to be brought up to an appropriate temperature between 2 and 8 degrees Celsius, and then has to be measured and diluted. And so it's a very sensitive and very I think it's a very sensitive process that needs to be handled with great care. And our pharmacists and our doctors and nurses have all implemented all of the necessary requirements to ensure that that's done in the best possible way. The dilutions and measurements process, our pharmacists, both in Witness and Runcorn, have helped with the implementation of the dilution and measurement of the vaccinations. So they come in the little vials that you can see on the screen here in these boxes that are maintained in the fridges. And as they have to be diluted down so that they can be administered to patients. We've also helped with management of the equipment and supplies for the vaccines. That's everything from cotton wool swabs right through to the needles that are used to administer them, alcohol gel and wipes, and just ensuring that everything is in the right place at the right time. It's been a great team effort, not just ourselves, but also with our local prescribers and with our nurses and other healthcare professionals. And so it's been a great team effort across the board. And then also the vaccination monitoring and safety for safety reporting. And so with the vaccine being quite new, it's vital and important that we maintain quite high standards of monitoring of the vaccine to ensure that every possible side effect or or issue with it is reported and monitored effectively, so that we can identify rapidly any problems that there might be. And that has produced some wonderful results as well that have been very, very important to ensuring that vaccine is safe, it has the right quality, and that it provides the right amount of effectiveness to overcome the pandemic as we have it at the moment. And a result of that, we're having we're not out of the woods, as is quite common phrase on the media, but the vaccine as it stands at the moment is producing some very, very positive outcomes for patients, and hopefully that will be maintained as we go forward. And so that's most of my section, I believe. I think this section's now Lucy's, if that's okay.
Yeah, that's fine. Thanks, Nathan. So just to quickly go through one of the biggies that we did last year, we've done in the last 12 months. Those of you know will know that we've already got a care home medicines management team. So we've got pharmacists and technicians that already had been supporting our care homes. And in Halton, that's been absolutely priceless, because we were able to just change and mobilize and help those care homes, because I think it was in about May, June time last year, obviously a lot hit the news about our care homes and making sure we gave them absolute, it was one of the highest priorities for us as a team, to actually even bringing in people from who didn't specifically work on care homes on a normal days basis to actually give this extra oversight to it. And that was what was called the care call to action. It basically covered a few areas, which was making sure medication review was done for care home patients, making sure care homes could access their medicines. They had contacts for all medicines queries, and there was a way of minimizing risk between transfer between settings. And like I say, we already had our care homes medicines management team. We supplemented it with some extra hours from one of the other pharmacists in the team. And I think that really, I'd say from the word go, the team just got on with it and helped make sure that they were always communicating with our care homes. If you need any help, let us know. You know where we are. But whilst at the same time trying not to overwhelm them, because the amount of information coming at them was amazing. So some of the things we were asked to do. Now, one of the real success stories for this last 12 months, I'd say it was about the end of March. We were approached. We do training for our care homes around basic handling of medicines, and there was a feeling that there may well be higher staff turnover or staff changes. And they needed to be able to make sure that staff's knowledge about basic handling of medicine safely in this setting was there was no drop in quality or in standards with regards to that. So we're asked to do a compact e-learning package very, very quickly that could be used with all care homes and social care staff. And I'd say within about 2 weeks that was up and running, ready to go. It's still there. It's still able to be used if necessary. But I think I'd say by about the Christmas time, we'd had a good over 300 people use that compact package. It was absolutely brilliant. It was so nice because we can track how many people are using it. We've also now supplemented it with the full learning package, which is a few hours. And again, that it's free to all our Halton care homes, because we do it in conjunction with Halton Borough Council. It's got full pharmacist, pharmacy technician oversight, and it's even been checked by Health Education England. And they're really on board with what we've been doing with our care homes and learning packages. So it's been put up as a real good example of doing things really well to support practical things to support, so that things could be maintained safely. Homely remedies. Now, at the very beginning, we needed to make sure all care homes residents had safe access to the likes of simple Linctus or paracetamol. So our pharmacists worked with our GP practices to make sure that if it was appropriate, there was a signed authority to say that could happen for that care home. So it was timely, they were able to get hold of it, and that they didn't have to waste GP time having to get access to a prescription. Bulk prescribing is something else. I won't go into detail, but it's a way of making sure, again, care homes have access to non-prescription, but they are prescribed, but it's done, say for argument's sake, thickeners was one of the ones we've used. we've done it for, whereby you could, it helps save time within the GP practices, help the care homes to manage their time, but at the same time kept it safe, made sure it was very specific to the patients that needed it. Another thing that we did was continued with all our medication reviews to make sure that if something was covert, it was still safe, it was still within legislation, you still had that pharmacist oversight, and it was still least restrictive in terms of medicines. Medication review was still ongoing. Proxy ordering is what we're doing now, which is about, so for those of you who order online through patient access, so this is a similar thing for care homes, so that they can also, with the right consent, order on behalf online, whereas before they'd still been doing it on the paper orders. So this is bringing care homes into using the electronic ordering as well. Again, it's so many benefits, reduces time across the board and makes it more accurate. And then we had, like I said, regular contact. Our pharmacists still kept up with the ward rounds when they were back up and running, and even though they were virtual, it still worked quite well and had input into MDT multidisciplinary discussions. So that sort of, the team that involved in that is very much a core team, but we supplemented it where we needed to. But we're now back to the core team, keeping going with that. So if you could move on, please, Nathan. Some of the service developments related to medicine. So some of it isn't all us. The community pharmacy isn't all us, but there was a minor eye condition service, which we commissioned the pharmacy side of it for, to again support urgent access to medication for minor but urgent eye conditions. So this is where you go to see your optician, your high street optician. And it's a similar thing to the care at the chemist. If you don't pay for it, the pharmacy services allows you to be able to get access to it relatively quickly, following an order, signed order from your optician. Nathan's already mentioned end of life. There are some national developments, and rather than me go into detail about it, if you wanted to, I can always get someone to come and talk to you about it. But the GP Community Pharmacy Consultation Service, which is what GPCPCS stands for, that's relatively recent. So that care at the chemist will help supplement that. So again, it's similar to minor ailments, but it's when you ring your GP, they have now got a system whereby if it's a minor ailment or it's one of the ones on that consultation list, which is the same list that NHS 111 also use, that they can refer you directly through to see your pharmacy, and there's a route back if there was needed to be some very quick onward referral to be seen a bit more urgently. There's a lot of safety netting in there. There's a lot of they have considered all the different angles in terms of it's quicker to get the advice from the pharmacist, and the pharmacist knows that if they need to send them back, this is what they will do. But in the main, it is just a way of being able to quickly get an appointment with your pharmacy rather than having to it's highlighting the pharmacy side of things, and then the care at the chemist can supplement that. There's a discharge medicine service which has only just gone live, and that's about patients being discharged and the pharmacy actually overseeing what medication and how if there's any gaps or any differences in the two. PODS, that's patient-owned medicine. So that was something that started before COVID, and we wanted to really build on it and advertise it, but couldn't do at the time because the footfall through hospitals and GP practices reduced massively. So that's something we will pick up again, but by chance, actually, in order to protect NHS supplies, it grew its own legs anyway. So this is patients taking their medicines in with them when they go into hospital. So that now you possibly will start to see a bit more about that, but it happened anyway because hospitals had specific processes in place to make sure it was all safe. So it's about building on the good work that ended up being done during COVID anyway. Now the stoma service, I'll only touch on this briefly, and if you wanted me to come back and talk more about it at some point, I can. So we've commissioned a stoma service, community stoma service across 6 CCGs in Cheshire and Merseyside. And the idea is that initially the prescribing of these specialist products will start to sit with specialist nurses, and over time they'll also build in clinical review. They're available to be contacted by patients. They are there available to support if something's not quite right or if there are any concerns, but it's also meant to be as flexible and adaptable a service to suit the wide ranging different needs. So there's a lot of patients who want a light touch, and there's there's a lot of patients maybe who need a lot more intensive support because their issues are more complex. So we're doing a lot of patient sessions, and we've got a patient group as well that links to the mobilisation of this service, so that we can actually take on board everything that patients have told us already and telling us as we develop this, to make sure that when it goes live in our area that we get it right from day one, because we don't want to cause any undue distress, anxiety, or what have you. But also we wanted to be able, there's a lot of, for every patient where it works really seamlessly, there's a patient at the moment who hasn't been seen since discharge and who really would benefit from this service. So it's a good, the real potential is there to improve quality of life for our patients who are living with a stoma. But yeah, at the moment we haven't got an exact go live date for it, because like I said, we want to be just right when we go live, and we're the second wave to go live, so we'll all go live first. And we're just busy finalizing a lot of the legality around any data transfer. If you wanted me to come and talk more about that, I can do, but there is a lot of patient groups going on at the moment to talk through that, and we're talking to individuals about it, and we are refining some of the communications about it as we get lots of useful information from patients. There's a medicines management dietetics pilot about to go live. That is just in a couple of practices, and what we thought we needed to do, well, we knew we needed to do for some time now, is to get some more dietitian reviews in community, in the practices. And so the idea is that is almost a proof of concept to show some increased dietitian review for patients on sit feeds and other feeds. And that way we can ensure that they're right for the patient's needs, and that they're supported with the food first approach and food fortification. And integration with our primary care networks now. Over the next 12 months, there'll be a lot of changes, I think, in terms of how we look as a CCG. But one of the big things for us, which I'd already started working on pre-COVID, and COVID has really helped in many strange ways because of the vaccination program and other work we've had to do to support our prescribers and patients, that we are keen to start more aligning what we do, so it's one seamless work program, as opposed to this is your pharmacist who sits here and this is your pharmacist who sits here and this is your pharmacist who sits here. Nationally, there's a huge drive and move to, that's just confusing for everybody. So if we've got pharmacy support across the whole patch, let's make sure it's a little bit more joined up and aligned, so that it really doesn't matter who employs you. We're all working to the same aim for our patients, but we might all just do it slightly different roles within that. So if you could move on, Nathan. And one of the biggies that's coming up, and this is really just to, it was been on previous slides that I've said, but this is one that's had a lot of discussion really locally, that we need to really get back up and running. And you might have seen stuff on the news about NICE, who'd issued guidelines around prescribing in chronic pain, and there'd been something on the news, I think it was last week, about this. So really this is this is one of the many areas that we'll be doing in the coming months, but we haven't, it's not set in stone what we will be doing. It's not set in stone how we'll be approaching patients, because what we're going to do is work with individual practices as to how we can work together to approach their patients. But it will involve education, because that, I mean, we'd already started a program of education, but this is about refreshing that and really bringing it up to date. We have what we're calling a resource pack locally that's been developed. That has lots of different elements that we can implement now with our prescribers and patients, to start tools to utilize to help get patients sometimes just to understand the key messages around this as they're starting to be prescribed it, but working with patients who are on this historically as well. So that's the audit and clinical review. Every practice we're going to ask to have some sort of policy or protocol around this, and have a register of patients who are on high doses, just so that we can keep a close eye on those patients. It is high priority. It's got a really high profile nationally. And I think what we will start to do initially is start to raise awareness with patients that this is happening and this is going to start becoming something that you'll hear about more and more. So it doesn't come as a massive surprise, and it sometimes gives food for thought to patients so that they can come armed with questions to ask their prescriber about. We have a pharmacist in our team who has done hair prescribing in pain. And Nathan's just about to qualify as well in prescribing, and he's also done pain. And what we thought was having a couple of pharmacists whose specialist area was pain would directly support maybe some PCN level clinics locally to give that real specialist pharmacist input, so that what we can have is something a little bit more taking it out of the hospital, but with having the secondary care specialists as our backup. But like I said, it's not set in stone yet. And the final slide, and this is more for when you when we send you these slides, you can have a look at, just to show the national high profile. It has been in media, and if Nathan, you could just move this on to the last slide, please. If you can't, anyway, I've put on some resources, there you go, and it's 2 patient stories on there. One was a very sad story about how basically there was a lot of learning. Actually, I say it's a sad story, but at the end of it, there's a lot of positive learning that says, how can we make sure this doesn't happen again? And we use that story a lot with our practices and our clinicians as a, the learning that came from that. This needs to not happen again. And Sean's story, which is a patient from the south of England who, through all the interventions they got, has really changed his life. Whereas before he wasn't he'd lost all his, I think he liked to do walking. He got back to doing that. It was been life-changing, because what he thought was he was set in stone to be like that for the rest of his life. By having non-drug therapy has reclaimed his life, if you like. So you'll have these slides so you can follow those. So it's really, this one was just to say, out of all of our work programs, this is the one that we're going to have to really think about how we do as well, to engage with patients. But it is one of our highest priority ones. So Nathan, on to the last slide. And that's it. Yes, thank you. So I know there's a lot of things in the chat, so I don't know if we want to go quickly through and check whether we've answered them as we've talked, or whether there's anything additional we can add.
Sorry, Dave, did you put your hand up? Did you just want to ask something, or was that a legacy hand? Oh, are you on mute, Dave? Oh, no, can't hear you, Dave. Oh, we can now, I think. No? I'm sorry, while I can't hear Dave, should we go to the chat box? And I think, if Diane, do you want to ask your question first, if that's possible? And then we'll go on to Nikki. She's got another question that she'd like answering as well.
First of all, thank you very much, Lucy and Nathan.
I was just about to say thank you. So thank you, Diane. You've taken my...
You answered my question that I'd asked earlier about people who are on low incomes due to the pandemic. They've lost their jobs and they can still avail themselves from care at the chemist, because they would be on free prescriptions due to their low income. Yeah. So you answered that one. There appears to be an issue now with patient access for repeat prescriptions. If you tick your little boxes of what you want on the repeat prescription on patient access, then try to fire it off, it won't accept it unless you write something in the little box at the bottom. This was raised through the PPG network with myself as the chair, and I thought I'd bring it to you today to see if it's been brought to your attention from anybody else.
No, it hasn't. I seem to remember a long while ago, I think I'm probably talking back into 2019, that might have been raised then, but nothing's been raised recently. But we can certainly take that back and have a conversation.
It may just confuse some people that they can't, they think they can't order. But if you just write, I just write in the box, nothing extra or something like that, and it accepts it then.
Okay. We'll follow that up.
And the third thing is, I wondered if you'd do this presentation to the next PPG Plus.
Yes, of course. Happy to.
I'll make sure you have the details of the meeting through Katie Horan, because she organises PPG Pluses for me now. And I think this would be really good for that group of people.
Absolutely, no problem.
Thank you very much.
Nikki, did you want to ask your question next?
Hiya, yeah. I've worked in the health improvement team, and I'm the lead for delivering the suicide prevention training across the borough. So with regards to the pain, the chronic pain and the opioids, is that factor in? Because I was at a conference in September and they were saying that there was an aim that all pharmacies would be trained on the Zero Suicide Alliance training by the end of March this year. So I was just wondering, do you know, that's the first point kind of, where's that at? Do you know?
I don't know exactly if it's community pharmacies, but I'll certainly find out for you, and I can even get somebody to get in touch with you so you could have a chat through it if you wanted to. We work very closely with our local pharmaceutical committee chief officer, who keeps me up to date and keeps my team up to date with community pharmacy initiatives. But when anything's raised to us about how far an initiative has been pushed with community pharmacy, I usually just ask her, could she explain to us what she's done? But I can certainly get yeah, I'll get some information for you about that if I can probably get your details.
Yeah, no problem. I'll pop my email address in the thing, because it's coming from personal as well, because even though I deliver the suicide awareness training and I know all the signposting, I know about asking the question, everything, when I was in that same position myself, it just completely went out the window. And I've got a chronic pain condition, it's endometriosis, and I'd had surgery in March 2019, and it just hadn't made a blind bit of difference. And I went back to my GP in the June, and when I went in, as soon as I got in the room, I just burst into tears. I was like exhausted with the pain, and my GP gave me a tissue and did me referral again. And at the time I was already on paracetamol, ibuprofen and tramadol, and they prescribed me Oromorph, liquid morphine. So then, clearly distressed, I went to the pharmacy next door, handed in my prescription, and I was just given a big bottle of Oromorph, no measure in it, no nothing, nobody asking any questions, was I okay, nothing. And it was just kind of off you pop. So, and like I said, I delivered the training, I have done for 5 years, and even I was in that situation myself, and it didn't flag to me, wait a minute, nobody's asked me here, am I okay? I'm stood here in tears, and you give me a bottle of morphine, and no kind of question, no advice around it, no nothing. And I just think that's an ideal opportunity to intervene. And because all pharmacies have got the consultation rooms as far as I'm aware, and it could have been done under the guise, this is a controlled medication. Do you mind if we just come in? I just need to go through a couple of things before I can give you the medication. And it could have so easily been done that way, and then they could have just gone into the conversation saying, I'm really concerned that you're so visibly upset and I'm giving you this medication, can I check where you are, what's going on? And they could have very easily asked the question then around suicide awareness. I think it's just a massive massive opportunity that we're missing.
Do you know, on our work plan, so we've got the work plan around opioids, one of the elements is community, what we can build in around community pharmacy, and what you've said is really interesting and given me some good food for thought about how we can work together with our pharmacies about this, because that's exactly what we're thinking. You know, they're the ones who hand this out, and there maybe are some simple additions or just some simple things that they could do, but maybe utilizing some cases where if this had happened, maybe that's just something that could be done.
It was just a bottle. There wasn't even a measure in it. Do you know what I mean? So there wasn't even, like, it was tablets, and I'd have to pop them all out of the thing, the sleeve or anything. It was just a bottle with no measure in it either. I mean, I deliver the training. I deliver the basic suicide awareness training across the borough. So I'm more than happy to kind of, if there's anything that we can do and do it at that more practical level, I can tailor it to the pharmacies.
Okay, that's great. If you can get me your contact details, we'll make contact, and we can have a bit more of a chat about where we go. Yeah, that's really useful. Thank you.
Thank you.
Thanks, Nikki. Anne, did you have a question you would like to ask next?
Yes, please. It was just going back to the care at the chemist and minor ailments. Is there any way that we can do like education and advertise the fact of how much these products cost the NHS if we don't purchase them ourselves? Because I think that a lot of patients will just look at it and they'll go, oh, well, paracetamol's 25 pence. And they don't know the £35 end of it.
So
Nathan?
a lot of that will come as part of the self-care program that we do. The plan initially before COVID was to launch with our patient participation groups, to do work with outreach. We did outreach in Runcorn and Shopping City. I even presented to a church at one stage. And so we're going to reach out to as many forums and as many patient groups and as many different localities as we possibly can across the area, to get the information out as best we can. And as I say, we'll have posters, we'll have the website. We should have little cards that we can hand out eventually, if that's possible. We'll also have patient information leaflets. And so the whole point is to get that information out. And we'll do that digitally, we'll do that in paper, we'll do that from face to face. As I say, the main reason it hasn't already happened is just because of the restrictions put in place because of COVID. And so those messages will go out as wide and as broad as we can make them. Facebook and social media, wherever we can post them, we'll post them.
Excellent. Yeah, I mean, as a former both drugs and OTC rep, I've been fighting this for years, and people don't really get it. You know, if we could do something like, if you buy your own paracetamol, more people can have knee replacements, etc. You know, just give a costing on it.
Yeah, we do have some materials we could utilize the exact message that so many of it's getting the right message, I think, for the right part of the population, because for some, I think what was done, not necessarily by us, but utilizing some of the national campaigns, it was a bit out of date in what would mean something to everybody. So a knee replacement might mean some to certain populations, but actually for the youngsters might not mean quite the same. It was just getting a variety of messages that were applicable across the patch, that I think everybody understands having more ambulances and more nurses and more doctors. But then ultimately we had the supply issue anyway with getting more nurses and more doctors, and I think we just need to make them as relevant as possible so that it really rings true with everybody who reads them. So yeah, we can go back and look at all of that again. And then sorry, my computer's going off. Because I think they are really valuable messages. Doing it like that makes it real, doesn't it?
It does, yeah. And as I say, I know it's difficult because this has gone on for years trying to get this into place, and it's not so simple. But yeah, thank you for your answer.
Thank you.
Okay, thank you, Anne. Paul, did you have a question you wanted to ask?
Yes, I did actually. Just a note of appreciation to Lucy and Nathan and their teams. I've seen great changes gone on over COVID. There's been some silver lining with it, hasn't there? I think the processes that we're using are changing, which probably brings me to my question. I was interested that you had an e-learning course for the OMS, for the procedures. And I wondered if a learning process could be developed for the patient access and the way we deal with the GP practices. I know I'm fairly okay with IT and stuff, but I think there's possibly a learning package that could be put together. I don't know if it's possible, or you maybe have considered it already, but I wondered if it was possible.
So would this be an e-learning that patients could use about how to, I don't know, order their medicines, manage their medicines, that sort of thing?
Yes, Lucy, that's what I was thinking of.
Do you know, we haven't investigated that specifically. And I don't actually know if something already exists. Nathan might know, but I think that's a really good idea. You know, just something else to support our population, whereas particularly as technology takes over more and more in terms of how we do things. And like Diane said before, on patient access, unless you fill this box in, you can't press submit. So people might just give up and go without their medicines, or then really be anxious and stress about it. Yeah, I think that might be a really good idea. And it might be worth us first of all looking if somebody else has done this across the country, or if there's anything national that we could use. There is a couple of things. There's one called oh, I forget what it is. I can certainly send you the details, that we looked at about 2 years ago as a region. And that might be something, and it was an app type thing, so that could also be something. So now I'm talking, yeah, I think there are things that out there we could possibly look at utilizing or giving us an idea to adapt. So leave that one with us. We will go and do some digging.
Okay, that's grand. Could I just do a quick confirmation? It did come up in the chat. When you've had the injections at Stobart Stadium, we had a date to come back to. I'm just confirming that that's the case, because there's been, I think, some confusion with some of the GP practices sort of checking that things have gone on. I just want to make sure that, I've had the question a couple of times, you just need to go back at the date that was given at the time of your injection at the same time.
Yes, that's right. So a lot of people will be given their date and time to come back at their first injection. So that's what, unless you're notified otherwise by your GP practice, that's your date and time to go back there. I'm aware that there may well be some occasions when they don't give you that date and time, but they will be in touch to give you that date and time before the time scales up for you to, when you're due to have, just before you're due to have your second vaccination.
Thanks again, Lucy.
Thank you, Paul. Lucy and Nathan, I just wanted to say thank you for such a fantastic presentation before I've got another question to ask. It was really interesting and very informative, and I've certainly gained a lot of knowledge from it. We've been sent another question in, and it was about the AstraZeneca vaccination. It was, what's the rationale or the reasoning behind the over 60s that can have it and maybe the under 60s it's not advisable? I just wondered if you could clarify that for me, please.
In terms of the rationale as to how the vaccines, this is going to sound very high level, but I'm just very concerned that information I tell you today can sometimes be different by the time something else has come out tomorrow or in a week's time. But how this vaccine is being utilised has very much been driven by the clinical trials and the impact that they think that that's going to have. But then because of the really good monitoring that's been going on around the use of the vaccine, and if you think about the millions of doses that have been given, that's like so much data and so much information about the safety and the effects of that vaccine that they're constantly reviewing to make sure that it's in line with what we're seeing in terms of use of that vaccine. So if you think about how we'd normally market a drug, we'd test it on X many hundreds of thousands, which is exactly what's happened. But then once it gets into practice, it can sometimes take years to get this many people who've used something that we've got used in a matter of months. So the wealth of data that comes from the adverse reactions or from any information that we get from the use of that vaccine has just been flooding in. So they're constantly looking at that to refine how it's used. So in terms of the age groups it's being used in, that was very much dictated by the clinical trials, as far as I know. Nathan, have I got anything that you? I'm just trying to drag my memory up in terms of all the details exactly about AZ.
So as Lucy says, it's principally in relation to responses to the information that we receive, and the more data and the more safety information that we get, the more that the response is tailored to each individual group of patients. And each part of the population, and so quite large in the media recently was the limits to those under 30 for AstraZeneca. Again, that was a very, 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 remarkably small patient population, but the data was acted upon very, very rapidly, and directions went out in response to all the information that we received. And so it's a case of, as Lucy says, we get the information, it's analysed across the board, specialists are employed, and we have for the instances of the under 30s, for example, there were specialist hematologists and specialists in from the hospitals and from from Oxford and various other universities across the board, all employed to provide information. That's all correlated centrally, comes out to us, and then we support locally with our GPs and our doctors and others to ensure it's implemented to maintain as much safety and the highest quality that we can. And so I think that's the main focus. And as Lucy says, the information that we have today potentially might change as we say it. And that, again, because we're consistently and rigorously adopting a very much data and information-led approach to managing these vaccines. And it's because they've come in, it's not been done in any way rashly. It's all been done very methodically and systematically. And it's followed the exact same procedures as we would do for any other medicine. But it has been done at a bit more of a pace to ensure the outcomes for the population as a whole across the UK. And so, but every process that would normally be adopted and applied to any medicine has been adopted and applied. And in some instances with this vaccine and the various vaccines that are out, it's a great deal more rigorous because we're getting that information almost in real time. Instead, as Lucy says, sometimes it takes years and years to accumulate the sort of information that we're getting. And so, you know, it's very much led on that information and response sort of situation at the moment, and will continue to be so.
Brilliant, thank you for that. Diane, did you have your hand up again?
Yes, it was about the vaccine, the thing that Paul brought up just before. Yeah, I received a text this morning to say that they were having to change dates and times due if you were on the Pfizer vaccine. So I phoned my GP surgery and it got altered from 12:05 to 12:10 on Saturday. But they said, I asked why it was being changed, and they said it was certain vaccines are coming on certain days and some aren't going to be available for people, so that's why they're swapping them around. Does that make sense?
Yeah, it does make sense. I mean, it's not, unfortunately, the way the deliveries work is that although they might have an idea when they're coming, they don't get the final confirmation until it used to be till very, very shortly before the actual delivery, but it's more now how they get that final confirmation nearer the time for their clinic. So they'll book the, sorry, my dog's trying to get out the door. Go on, off you go. Yeah, the deliveries aren't as clear cut as you think possibly. It's about having to juggle the different deliveries, and sometimes nationally they might change the delivery schedule, so then they might have to make some slight tweaks to it. So in terms of the second doses, in the main, it's not that the supply is not there, it is there absolutely. It's just when it's going to arrive, which should more or less be the date and time that you should have it, and in the main it is, but sometimes it's been tweaked slightly, so then they have to change the clinics ever so slightly, which is sometimes why they're not always giving out those dates and times for the second dose, just because they want that absolute confirmation of the delivery before they go booking patients in. And it's got better as time's gone on.
Thank you. She did mention something about the clinic times a change as well for the vaccine.
Yeah, and I think I think because of where it is as well, you know, as lockdown starts to change, I don't know how it's going to change that whole approach, but yeah, I think they're just having to be very, very careful that as soon as they know when their delivery is going, does that match how we've booked everybody? And yes, it does, or no, it doesn't. So we're going to have to tweak things ever so slightly.
Yeah. They seem to be getting really busy now because people are saying they're queuing in the cars up Liverpool.
Oh yes, we saw that the other day.
To get in. But I think that's good because people are enthusiastic to have the vaccine. They're not quite as reticent as they were at the beginning. And I think that's a positive step.
Yeah.
It's very, very
sorry, I can't find how to put my hand up. I don't know where it's gone. I know I'd put a request in to possibly have mine a bit earlier because I'm working on the elections and my second dose was due the day before the elections, and it is the Pfizer one that had an we've heard reports that you're a bit poorly more on the second Pfizer, because it was okay on the first. And my practice confirmed they were just waiting for appointment slots. They hadn't actually been allocated any yet, but they rang me yesterday and I'm in on Friday. So I think that's maybe part of it as well, kind of juggling the different GP practices and getting them in the slots.
I think part of it is this, with the Pfizer one, the storage of it is the key thing. Once they've took it out of that freezer, there's a deadline to be able to have to use it. So it's almost, once those deliveries are in place, there's a finite amount of time before anything can be changed. So it almost has to be, right, we know exactly when this is now, because it can't change, because the minute they took it out of that freezer, it's got 5 days on it, and then we, you know, this clinics have to use it. So it's fitting everything together so that nothing gets wasted. The clinics have as much time as possible to use it within that 5 days, but at the same time, people then don't start saying, well, actually, I can't get patients into the clinic, so we're now going to risk wasting some of it. And once it comes in its big, what we call pizza box, they can't sort of take parts of that out. So ultimately, it's a case of, yes, we've got all the patients we need to book in, so no doses are wasted. Because it's not as simple as, oh, it's all right, it can sit on the shelf if we don't get everybody, and we absolutely need to have everybody there for all those doses.
So is the truth in that if you've got a late on appointment, if there is spare vaccines, people have been getting them? Because I keep hearing that as well.
So what it is that there's cohorts they have to work to. So you've probably heard about those nationally. Cohorts 1 to 9 is what they've been working on, which is 50 years and above. So within those cohorts that they're allowed to use nationally, they have had reserve lists at the end of the day. So they might have patients booked in and then so many extra that they haven't called in, which might actually be health and social care staff or others within the cohorts that are not necessarily booked directly in at that point, but it would still be appropriate for them to have the vaccine. So they then get phoned at the end of the day if there's so many doses that might be left, so they don't waste them. So I would say that the message is where they're pulling in reserves, it's within still got to be within the cohorts that this will be used for. Otherwise, they have to get special permission to use it outside of those cohorts. Right.
Okay. So they've just called in like the over 45s, haven't they? That's gone out today, I think. The over 45s can book in. So if I'm booked in on Friday, is it worth me taking somebody in that cohort with me just in case there's any spare?
Well, they don't usually know towards the end of the day. And I think at the end of the
at 5 o'clock.
Oh, 5 o'clock. I don't really know what time the clinic's going on till, I'm afraid, on Friday.
Right, okay.
I think at the end of the day, you might have to speak to them directly, speak to your practice and see what they say. But
yeah,
I wouldn't recommend just always taking somebody in the same cohort just in case, because it could be a completely wasted journey. Because the Pfizer one, I would say, usually they've got a way of communicating out how they do the reserve lists. So every practice will have their own little reserve list that you might find that they're already taken up.
People keep saying that's happening. So I was like, right, okay, I'll find first before.
Do you know where it's happening? Where it's happening, where things aren't happening where they're supposed to be, they are being followed up outside, afterwards, because everybody gets to see exactly who's they've done age-wise. So if it becomes obvious they're doing people they're not supposed to be doing, NHS England do clamp down on that.
Okay, cool.
We have someone in the CCG who's seeing exactly what's going on, and we'll pick it up with them if things aren't happening correctly. So it's being monitored quite carefully. So I think that every GP practice will have its own little reserve list, so that they know towards the end of the day there might be 5 each that they can call in should they have to.
Right, cool. Thanks for clarifying that.
Okay, Dave, did you have a question you wanted to ask?
As long as my microphone works, yes. Well, there's a couple of things actually. Just first going back into Nathan's presentation, they were talking about the £550 million cost. Is there a breakdown either for Halton or Cheshire Merseyside that could be used because I think when you're doing a campaign, if you focus on the money that's local, as Lucy said, people will relate to it more, in that than a national figure. That was one. I'll just go on. We've got an offer. Can we help at all around this campaign? Because if we can, we'd be delighted to join in, take part, and promote it as much as we can, if that's okay.
That would be absolutely wonderful if that's possible. We absolutely love help from every quarter that we can get it from. As I say, we'll do our very best to get the information and message out to all different groups and to the public. The most important thing is that every member of the public locally gets the information so we can have the maximum benefit locally. We do have, in answer to your first question, we do have access to more localized data, and we can draw out information from the prescription data that we do receive. So we can adapt the figures to more or for a more local picture. And we have developed some resources as well previously that do reflect that, and so we can work on that as we go forward as well, to reflect the situation as time goes on.
Thank you. Would it be possible to send us some copies of the resources as well, the various leaflets, so we can use them if we promote anything out?
Yeah, well, so we're limited at the moment on the hard copies that we have, but they are all available currently on the Halton website, for access. And so when we do get hard copies available, we will make them available to our practices and to yourselves and to the PPGs and other groups as well. So that will be in process of time.
Thank you.
But various resources are already on the Halton website.
Okay, we'll have a look on there for it. Thank you. Just on with regards, we had some feedback about the second doses, second jabs. We had a few people who were unable to be attended for sessions and were unable to have the jab. I think, as Lucy said, possibly because the vaccine that we'd had wasn't available on the day. I know it's spoken to the CCG, and the answer they got was, I think Halton Stadium initially shouldn't have been given out second dates when they did the first date, when we gave the first jabs, because there wasn't guaranteed supplies that we, obviously we know of. And one other thing we picked up was actually more one of the Appleton pharmacy. A couple of people had turned up and it was closed when we had appointments. But looking into that, what we found is it appears there was a problem with the national booking system early on that had a glitch that allowed people to get the dates, but it then didn't send through the information through the system. So that seems to be sorted a little bit now. And pardon if my internet connection's just gone a bit dodgy. I think that was it. But the feedback we've had on the vaccines, certainly we've been collecting feedback from the stadium, and I think we've had about 300 odd comments, and 99.5% of them have been 5-star rate, and everybody's loved it. There's been, been a couple of minor issues, but it's run, considering how quickly everything's been set up, it has run very, very smoothly, and I think the whole system needs praising for that. And I can see Diane's hand is up, Louise. I don't know if Diane's got another question.
Yeah, just a question. Well, it's two things. I think it's brilliant the way that they've run out this vaccination program. It's been fantastic. Has there been a lot of DNAs that's caused issues?
I can't tell you off the top of my head exactly the rate of DNAs. There has been DNAs, but like I said about the backup lists, the reserve lists, I think they've been trying to anticipate where they think there might be DNA. So I think with second doses, they thought there might be some more DNAs just because of patient situation changing. Also with potential that, I don't know, some might be able to get it. Some patients were getting offered it from a couple of different routes and what have you. I think that they have been trying to anticipate where there might be a problem with DNAs and mitigate that right from the word go. In other words, having their backup lists for this. So I can find out more for you about exactly about their DNA. Right? The reason I'm not 100% clear is because we're stuck with the making sure the vaccine's handled properly rather than actually spotting who's coming through the door, if you get my drift. So I'll definitely I can follow that up for you, Diane. But as far as I know, when we've had conversations as a CCG with our sites, when they're planning it's at that point they're trying to anticipate. So if we're likely to get DNAs, what should we do? What will we do about this? How will we manage that? And in essence, the main thing is so we don't waste anything.
Thank you very much. Thank you.
And a little bit on from that too, Lucy, is that we do support substantially with the preparation and storage of the vaccine. So we often, it's often one of our pharmacists that would actually have the key to the fridge for the vaccines. And so we would ensure that where possible, the right amount of vaccine goes out for the right number of people. And that's monitored very, very closely, particularly towards the end of the day. Whenever, you know, we're literally counting out the little vials out of the fridge to ensure that they're handled safely, effectively, and that there's very little wastage whatsoever.
Yeah, that is an important point. They don't get past us if there's too much vaccine already out on the floor. So there's no more goes out until we're absolutely sure there's the number of patients through the door for it.
That's wonderful. Thank you. I just wanted to say it's been such a really good session. I think it's been really interactive, and there's been a lot of sort of communication and lots of knowledge building, certainly from my point of view. So thank you both for coming along, and thank you for your presentation. It's been fantastic. So I think I can't see any more hands up. I can't see any more further questions. Did you say today, could we have a copy of the slides that you've got today, or is that possible to share it?
Yeah,
That would be fantastic.
No problem.
So yeah, I just wanted to say thank you again. It's been fantastic. I've really enjoyed it.
No worries. And if there's anything that we've said that we could do anything more about in the future, you know, like I said, there's a few things I said I can't go into too much detail because we're doing it somewhere else and it would have taken too long, but please say if there's anything specific you want us to come back and talk about.
That's brilliant.
So Lucy, sorry to interrupt, just let us know if there's anything that you've got coming up that we need, and yeah, we'll jump on it.
Yeah,
okay.
Yeah, that would be great. Thank you.
Okay, so thank you both again for coming, and thank you everybody else for joining us today. It's been really informative, and I'll keep everybody updated with the next one, but thank you both for coming along today.
Thank you. Thank you for asking. Okay,
bye. Thank you soon, Lucy.
Thank you.
Thanks.
Bye.